Greetings from Indian Journal of Anaesthesia. I, Dr. Riniki Sharma, will be presenting an article published in the April 2024 issue of Indian Journal of Anaesthesia. This is a prospective observational study comparison between perfusion index, pleth variability index, and pulse pressure variability for prediction of hypotension during major abdominal surgery under general anesthesia. So general anesthesia induction can lead to severe hypotension and bradycardia. It depends on factors like cardiac status of the patient, type and dosages of anesthetic drugs used, and the preoperative fasting status of the patient. In patients without any significant comorbidities, it is associated with the patient's volume status. Non-dynamic parameters like perfusion index and dynamic parameters like pleth variability index, stroke volume variation, and pulse pressure variability are predictors of volume status. There is lack of literature explicitly comparing perfusion indices such as perfusion index, pleth variability index, and pulse pressure variability for predicting anesthesia-induced hypotension in major abdominal surgeries. So the primary objective of this study was to establish cutoff values for perfusion index, pleth variability index, and pulse pressure variability to predict hypotension. And the secondary objective was to compare their positive and negative predictive values within 15 minutes of induction. Ethical approval was taken from the Institutional Ethics Committee and trial was registered under Clinical Trial Registry of India. The study design was a prospective observational study. The participants included patients of adult age groups 18 to 60 years of age, ASA grade 1 and 2, scheduled for major abdominal surgery under general anesthesia, requiring at least 2 hours of arterial blood pressure monitoring. Patients with hypertension, cardiac, hepatic, or renal dysfunction, bilateral pulmonary disease, and difficult airway were excluded from this study. All the patients completed 6 hours of fasting for solid foods before anesthesia. After taking the patients inside the OT, ASA standard monitors were connected. That is the non-invasive BP, pulse oximetry, ECG and temperature probe, and IV cannula was secured. The left radial artery was cannulated under local anesthesia. The Mindray Benevue T5 monitor was connected to the arterial line to measure pulse pressure variability. The Massimo Radical 7 co-pulse oximetry monitor and Mindray Benevue T5 pulse oximeter were put on the same site to get PVI and PI values respectively. All the patients were given intravenous fluid with Ringer's lactate with the total volume deficit calculated according to the Halliday-Seeger formula. The trachea was intubated with endotracheal tube after giving IV fentanyl 2 mg per kg, propofol 2 mg per kg, and vecuronium 0.1 mg per kg. The patients were put on volume control mode of ventilation with 6 to 8 ml per kg tidal volume titrated to end-tidal carbon dioxide of 30 to 35 centimeters of water and maintained with nitrous oxide and oxygen in a ratio of 60% to 40% with 1.5% sevoflurane. The patients were extubated once extubation criteria was fulfilled. The data was recorded by an anesthesiologist who was unaware of the study protocol. Heart rate, systolic BP, diastolic BP, mean arterial pressure, perfusion index, pleth variability index, and pulse pressure variability were recorded at baseline and at 1 minute interval till 15 minutes after tracheal intubation for the purpose of the study. Otherwise, all these data were recorded during the entire intraoperative period. In this study, hypotension was defined as drop in systolic blood pressure more than 30% below the baseline values, and it was treated if needed by rapid IV fluid bolus of 10 ml per kg and mefenterin 6 mg boluses. Bradycardia was defined as decrease in heart rate more than 30% below baseline values and was treated with IV atropine 0.6 mg boluses. The primary outcome was to identify the cutoff values a perfusion index, pleth variability index, and pulse pressure variability to predict hypotension by 5 minutes after induction of general anesthesia. The secondary outcomes was to compare the positive and the negative predictive values of these three parameters with the established cutoff values after 15 minutes of induction. The sample size was based on a study in patients undergoing spinal anesthesia, where perfusion index was a predictor of hypotension. For alpha equal to 1.96, 95% confidence interval and 99% power, the sample size was found to be 127. Assuming 10% attrition, the total sample size was calculated as 140. Though statistical analysis was done using SPSS version 23, independent sample t-test, paired t-test, chi-square test was used for analyzing. For comparing more than two groups, ANOVA test was used. The linear correlation between two continuous variables was done by Pearson's and Spearman's correlation. Receiver operating characteristic, the ROC curves were plotted to determine the diagnostic performance and the best cutoff for the continuous variable in predicting a dichotomous outcome. The statistical significance was kept at p less than 0.05. So the total analyzed were 140. These are the baseline demographic data. In results, it was found that at 5 minutes, 51 patients had hypotension, and at 15 minutes, 63 patients had hypotension. So at 5 minutes, it was found that the perfusion index had a cutoff of 3.5, which was statistically significant, and the sensitivity and specificity ranged from 65% to and 73% respectively. Similarly, the pleth variability index, the cutoff was 11.5, statistically significant, sensitivity was 69%, specificity was 75%. For pulse pressure variability index, it was found that the sensitivity was 69% and specificity was 64%. At 15 minutes, only the pleth variability index was found to be statistically significant with a diagnostic accuracy of 60%. This is the figure representing the area under the ROC curve for perfusion index, pleth variability index, and pulse pressure variability at 5 minutes. The mean propofol doses was 93 milligram in hypotensive patients as compared to 90 milligram in non-hypotensive patients, which was statistically insignificant. So, from this study, it was found that the perfusion index has a positive correlation with the systolic BP, area under the ROC curve, and the pleth variability index had a negative correlation with the systolic BP. The pulse pressure variability may not be reliable to predict anesthesia-induced hypotension and is more a predictor of volume status. It was attributed that the intrathoracic pressure and pulmonary vasculature capacitance affected by the patient's inspiratory effort intensity could lead to the unpredictable heart-lung interactions, explaining the lack of pulse pressure variability's predictive value in this study. Patients with low peripheral vasoconstriction, that is low perfusion index, are more prone to post-induction hypotension, while those with higher perfusion index and lower vascular tone are less likely to experience it. This study suggests that the pleth variability index is a better predictor of post-induction hypotension as compared to pulse pressure variability and perfusion index, with the PVI maintaining a significance over time. The strengths of this study include a robust sample size, and the limitations include the inability to control all respiratory variables and considerations for patient-specific factors. So, from this study, it can be concluded that perfusion index, pleth variability index, and pulse pressure variability could predict hypotension at 5 minutes after induction, with the pleth variability index showing higher diagnostic accuracy even after 15 minutes of anesthesia induction. Thus, pleth variability index exhibited statistically significant association with hypotension, boasting superior sensitivity, specificity, and positive predictive value as compared to perfusion index and pulse pressure variability. Thank you.